Welcome back to the Movement PhD. I'm Dustin Hardwick, a physical therapist with a PhD in movement science. Today we are switching gears and starting our unit on the knee. In this first part of the knee unit, we will be discussing bony anatomy, alignment, and arthrokinematics. As usual, you can find slides in sync with the video on YouTube and Spotify. You can also listen on all of the major podcast providers. If you prefer to read, you can find the slides with notes and a summary on my Substack. Now that we have our slides pulled up, let's get started with Season 1, Episode 10, The Knee Joint, Bony Anatomy, Alignment, and Arthrokinematics. Let's get started with an overview of the purpose of that knee joint. The knee joint is a lower extremity joint, so it works together with that hip joint and that ankle joint. And a lot of the things that it's involved in are weight bearing, so things like standing and walking. It's really important during locomotion, both to shorten the limb with that knee flexion during swing phase, and to support the body against gravity, and also allow a little bit of flexion during stance phase to absorb some of those ground reaction forces. The knee joint lacks a lot of bony stability. You have a rather large femoral condyle on a rather flat tibial plateau. Therefore, it relies on those ligaments, that capsule, and those muscles for its stability. Therefore, it is one of the most frequently injured joints in the body. The knee is referring to three different joints. We have the tibiofemoral joint, we have the patellofemoral joint, and then we have the proximal tibiofibular joint. We're going to talk about the most important one first. That's that tibiofemoral joint. This is a synovial hinge joint between the distal femur and that proximal tibia. The articulation itself occurs between the medial and lateral condyles of the femur and the medial and lateral plateaus of that tibia. The medial condyle and the medial tibial plateau both extend further in that anterior to posterior direction, which is going to have some implications for that screw-home mechanism that we'll talk about a little bit later. There are two other joints that are part of that knee. We have the proximal tibiofibular joint and we have that patellofemoral joint. The proximal tibiofibular joint is a plain synovial joint between the fibular head and the lateral condyle of that tibia. It doesn't have a lot of motion, but has a little bit of gliding in that anterior to posterior direction and really mimics the movement of that ankle. It's there for some shock absorption and to reduce some torsional stresses on that tibia and that fibula. Then we have our patellofemoral joint, which is a plain synovial joint between the articular facets of the posterior aspect of that patella and then the lateral and medial condyles of that femur itself. This is a very complex joint that has a lot of ligaments and tendons involved, and we'll talk about that in a little bit more detail in some subsequent slides. I'm going to start with a review of anatomy. We're going to start with our distal femur. This is a left femur, and we're going to go from medial to lateral. Most medial, we have our adductor tubercle, insertion point for many of our adductor muscles. We have our medial epicondyle. We have our medial condyle, which again extends further in that anterior posterior direction. So remember that as we get to the screw-home mechanism next. We have our intercondylar fossa here in the middle part. Now we go to our lateral condyle and our lateral epicondyle. We're going to continue our discussion of anatomy with the proximal tibia. We're going to go from medial to lateral. We have our medial tubercle here. We have our medial tibial plateau and condyle here. We have our tibial tuberosity in the middle on the anterior aspect. We have Gerdy's tubercle over here on this lateral condyle. This is our lateral condyle, lateral tubercle, and our intercondylar eminence right here in the middle. I also want you to note how much larger that medial tibial plateau is. Again, thinking about that when we get to that screw-home mechanism. On the posterior aspect, we have our soleal line running to the posterior aspect of our tibia here. Next up, we have our kneecap or our patella. It's an inverted triangle, so you have your base on top and you have your apex on the bottom. This is a left patella because the lateral facet is much larger than that medial facet. So that's how to always know which patella you have. Look for the larger facet that always goes on the outside. So if I have a lateral facet on looking like this, as I turn it around like a real kneecap, that's going to be on the outside for a left patella. Now that we have reviewed the anatomy of the knee joint, let's look at alignment of the knee. We're going to start with the Q angle, which is a measure of the knee angle in the frontal plane. So we're going to take a line from the ASIS to the midpoint of the patella, and then a line from the tibial tuberosity to that same midpoint of that patella. We're then going to measure the angle between these two lines. A normal Q angle is going to be approximately 15 degrees when you're looking at all populations, but there are some gender differences here. So males are going to have a smaller Q angle with a mean of approximately 13.5 degrees, whereas females are going to have a larger Q angle of approximately 16 degrees. Whenever you have a larger Q angle, it's going to mean that there are more lateral forces on that patella, making you more likely to have patellofemoral pain problems or subluxations or dislocations. Continuing with our discussion of frontal plane alignment of that knee joint, whenever you have a Q angle that is greater than 18 to 20 degrees in males and greater than 22, 23 degrees in females, that's going to be Genuvalgum or knock knees. So whenever you have a Genuvalgum alignment, there's going to be compression to that lateral compartment, so compression to that lateral meniscus, and distraction to that medial knee, so there's going to be a distraction force on that MCL. Genuvarum is going to be the opposite of Genuvalgum. This is bow leg. So we have a Q angle that is less than normal, so we're at 5 degrees, or we're at neutral or even into an actual varum position. When we're in this varum position, there's going to be compression to the medial aspect, so compression to the medial compartment, medial meniscus, and there's going to be distraction to the lateral aspect, so distraction on that lateral collateral ligament or those lateral structures of that knee. Now let's look at alignment of the knee in the sagittal plane. When you have hyperextension of the knee, we call that Genu-Recurvatum. So with that hyperextension, those ground reaction forces are going to lie anterior to that knee joint. Because of that hyperextension, you're going to get some tensile forces on that posterior capsule and that ACL. Both of these structures limit hyperextension. So if we're standing in hyperextension, there's going to be increased forces on that posterior capsule and that ACL. The other thing it's going to do is increase the stress on that knee joint itself because there's a smaller contact area. Whenever we're on the anterior aspect of that femoral condyle, that's a much smaller convexity than when in neutral. It's going to put those forces across a smaller area to that medial and that lateral meniscus. So what are the reasons why we might have hyperextension or that Genu-Recurvatum? With a severe Genu-Recurvatum, that is most likely the result of weakness or paralysis of those quadriceps. And you're probably thinking, why would you have hyperextension with a weak quad when your quads are an extensor? Well, it's because of the internal versus those external forces acting on that knee. So your quadriceps is the only internal moment for knee extension. So if I don't have that internal moment for knee extension, I have to create an external moment for knee extension. How do I do that? I bring that ground reaction force or that line of your body weight anterior to the knee to substitute for the lack of quadriceps. Let me put this in a different way. If a line falls anterior to a joint, it's an extensor. So if a ground reaction line is anterior to it, it's an extensor. If it falls posterior to that joint, it is a flexor. If I do not have quadriceps and that line of gravity falls posterior to the knee, it's going to cause my knee to flex. And without quadriceps, my knee is going to buckle and I'm going to collapse. Therefore, with paralysis of that quadriceps, I need to keep that line of gravity anterior to that knee at all times. So one way to do this is to hyperextend at the knee. The other way, which we'll talk about next week, is to lean our body forward. So again, the most common cause for severe Genu-Recurvatum is weakness or paralysis of that quadriceps. The other reason could be a lack of dorsiflexion. So in closed chain, dorsiflexion involves that tibia rotating over a planted foot anterior. So if my tibia is unable to rotate over that foot during stance phase of gait or when standing, my tibia is always angled back from my foot. So it's always angled posterior due to that lack of dorsiflexion. Therefore, to get my body weight over that foot to either balance on it or to transmit my body weight forward during gait, I have to hyperextend at that knee to get that body weight forward because my tibia can't roll over that ankle in that closed chain dorsiflexion position. We'll review this again in the ankle unit, and we'll also review it again in the gait part of the knee next week. The most common reason for less severe hyperextension is just habit or poor motor control. If I stand in hyperextension, then I don't have to use my quadriceps to stand up because I put my body weight anterior to that knee joint. So if I'm lazy and I just don't want to use muscles when standing, I can just stand out in hyperextension. Our body is always looking for the position that is the least taxing on our body. So it's very common for our body to lock out into hyperextension just to take some of that load off of those quadriceps. So a lot of less severe hyperextension is just habit. You may find yourselves, if you're standing for a long time, habitually locking out those knee joints. So next time you find yourself doing that, unlock those knees a little bit and take some of that stress off of that knee joint and put it on to those muscles like that quadriceps. Now let's talk about those ground reaction forces during double limb stance and in the next slide, single limb stance. In double limb stance, that ground reaction force line passes from the hip joint to the ankle joint and should fall through the middle of that patella when we have good alignment of that knee. Therefore, there are no compressive forces that are greater on the medial or lateral aspect. Everything is in balance. When we have that Genuvarum with the knee joint in a varus position, even in double limb stance, that line of gravity is going to fall medial to that knee. So we're going to have some compressive forces on the medial aspect, and we're going to have some distractive forces on that lateral aspect. So compression to medial meniscus, distraction to that lateral collateral ligament. If we have Genuvalgum or knock knees, it's going to be the opposite. Now my knee is going to fall inside that line of gravity or that ground reaction force line. So I'm going to have compression to the lateral aspect, and I'm going to have distraction to the medial aspect. So distraction to that MCL, compression to that lateral meniscus. When I go from double limb stance to single limb stance, I have to shift my body weight over that standing leg. By shifting my body weight over that standing leg, I move that ground reaction force line medial to that knee. Any force that's medial to the knee is a varus producing force. So with that varus moment, I get medial compartment compression, so compression to medial meniscus, and lateral compartment distraction, so distraction to that LCL. This is a normal response to single limb stance. Let's now talk about the screw home mechanism. The screw home mechanism is a transverse plane rotation that occurs during terminal knee extension to lock that knee out. So in open chain, it is 10 degrees of tibial lateral rotation. In closed chain, it's going to be 10 degrees of femoral internal rotation. So what is the purpose of this screw home mechanism? Is to increase the congruency between the femur and the tibia. It's also going to put that capsule under tension. So the goal here is to increase the stability as you're locking out that knee into extension. So why does it occur? The most important reason is anatomy. Remember earlier, I talked about the increased length of the medial femoral condyle in that anterior to posterior direction, as well as that increased length of that tibial plateau in that anterior posterior direction. Because of that, that screw home mechanism increases the contact area between that larger condyle and that larger tibial plateau. Let me review that one more time. During terminal knee extension, you have 10 degrees of tibial lateral rotation in open chain and 10 degrees of femoral internal rotation in closed chain extension. Let's talk a little bit about the function of that patella. We reviewed the anatomy earlier, but now let's talk about some of the function and the purpose of that patella. So its main purpose is to increase the moment arm of your quadriceps tendon. So remember, your moment arm is the distance between the center of rotation and where that tendon passes by it. Therefore, that patella increases the distance between that quadriceps tendon and that center of rotation. Without a patella, that quadriceps is going to run right across the front of that femoral condyles. That's going to be a smaller mechanical advantage. So that patella gets that tendon and moves it further away, allowing those quadriceps to have a mechanical advantage for knee extension. It also protects that tendon. If it was just running over the anterior aspect of the femur, there'd be a lot of friction under that tendon during knee extension with that knee inflection. The position of the patella has some functional implications. If it's a low-riding patella, there may be some different stresses on that quadriceps tendon, so you're more likely to have tendon issues. If your patella is running high, it's not going to seat very well between those two femoral condyles. Therefore, it's going to be at risk for dislocation. And those dislocations occur mainly to the lateral aspect, which we're going to get to in our next slide. Let's talk about the forces that act on that patella. So the largest force acting on the patella is the bowstringing effect of your quadriceps. And that is a laterally directed force on that patella. So what do I mean by a bowstringing effect of your quadriceps? Well, your quadriceps, as it contracts, it tries to pull in a straight line from the muscle belly of the quad to the insertion on that tibial tuberosity. However, if you remember from earlier, we have a slight Q angle that's happening at that knee joint. Therefore, there's a valgus alignment in that frontal plane. Because of that valgus alignment, combined with our normal anteversion of the shaft of that femur, your patella is medial to the line formed between your muscle belly of your quad and its insertion at that tibia. Therefore, as my quad contracts, it's going to try to pull that patella back to that straight line, which is a lateral directed force. Therefore, the larger the Q angle, the more bowstringing force is going to be on that patella, or the more laterally directed force that's acting on that patella. What are some other lateral directed forces at the patella? Your IT band is another important one. Your IT band attaches to the superior lateral aspect of the patella, and that is a lateral force on that patella. So if you have any kind of muscle imbalances where that TFL is overactive and therefore putting tension on that IT band, that's another lateral force at that patella. So if you have weak glute med and TFL is trying to take over, not only are you going to have an increased dynamic Q angle, but you're also going to get an increased direct force in that lateral direction of that patella from the IT band itself. So what's counteracting those laterally directed forces at that patella? Well, the first is just anatomy. That larger facet on the posterior aspect of that patella is going to seat into that lateral condyle of that femur, so that's going to hold it in place. The only active force, or the largest active force in the medial direction, is that VMO, or that vastus medialis oblique fibers. They attach further down on the tendon, and they attach at an oblique angle to that tendon. So activation of that VMO is a medial directed force to counteract all of those lateral forces that are acting on that patella. Therefore, biomechanically, it makes sense that we would look to activate that VMO in a patellofemoral pain type of situation to prevent those lateral forces and to prevent that lateral compression underneath that patella. The problem is it's very hard to activate that VMO in isolation. So what can you do? Well, the first thing you can do is fix the alignment of that hip and knee. So work on improving the strength of that glute med, reducing the effect of that TFL. That will get that knee in better alignment. And as we get that knee in better alignment, for a lot of patients, we get a more overall activation of that quads, including that VMO. Now let's talk about those patellofemoral joint reaction forces. In standing, most of the forces of the quad to the patella and from patella to that tibia or in the vertical direction. So there's not a lot of compressive forces between the patella and those femoral condyles. However, as we go into a deep squat or deep knee flexion, now the forces are more horizontal. So the force of the quad to the patella and also from the patella to its insertion in the tibial tuberosity, those are going to be more in that horizontal direction. So when you add those two force vectors, you get a much larger horizontal compressive force. Therefore, you get more compression the deeper you go into a squat. Now let's review knee joint osteokinematics and a few important positions of that knee joint. So again, your knee joint or your tibiofemoral joint is a hinge joint. So the primary motion is going to occur in that sagittal plane. So it's going to be flexion and extension. So knee flexion, normal range of motion is approximately 140 degrees. The infeel is going to be soft. Remember, soft infeel is approximation of tissue. In this case, it's the approximation of the hamstrings with the gastrocsoleus complex. Knee extension, you should have 0 degrees or close to 0 degrees of knee extension for normal range of motion. Your infeel is going to be firm, and it's going to be ligamentous because the posterior capsule and ligaments plus that ACL are going to limit that knee extension. Our capsular pattern, or what is the limit in motion when the capsule is involved in a pathology, is going to be flexion, much more limited than extension. So when we do our goniometrical measures of the knee, when the capsule is involved, you're going to see that flexion is going to be grossly limited and extension is only going to have a little bit of limitation. The open pack position of the knee joint is in approximately 25 degrees of flexion. Remember, open pack position is the position where that capsule is in the least congruency. So this is the position you want to do your manual therapy on because it'll allow for the most accessory movement within that knee joint. The closed pack position is full extension. Because of that screw home mechanism, when you get full extension of the knee, you get that tibia externally rotating, or in closed chain, that femur internally rotating, which puts that capsule under full tension. So our closed pack position of the knee joint is full extension with that screw home mechanism. Our final topic is tibiofemoral joint arthrokinematics. Let's just review arthrokinematics and the rule first. So remember, when we have roll and slide as our arthrokinematics, the rule is when you have a convex, which means rounded, surface moving on a concave or depressive surface, the roll and slide is going to occur in the opposite direction. So now let's apply that rule to our knee joint here. So in closed chain extension, which is sit to stand, so femur is moving on tibia, so convex moving on concave. We have an anterior roll because the segment that's moving is moving anterior, so it's going to be an anterior roll and a posterior slide. So one more time, closed chain knee extension is anterior roll and posterior slide during that sit to stand. Now let's talk about closed chain knee flexion, which is femur on tibial movement in the posterior direction. So it's going to be a posterior roll and an anterior slide. Again, we have a convex femur moving on a concave tibia. The segment is moving posterior, so the roll is posterior, and based on our roll, the slide is anterior. Let's review both of those really quickly for closed chain. Sit to stand, anterior roll, posterior slide. Stand to sit, posterior roll, anterior slide. Now let's talk about open chain knee extension. So now we have a concave tibia moving on a convex femur. When you have a concave surface rolling and sliding on a convex surface, the roll and slide are going to be in the same direction. So for tibia on femur extension or a knee extension, the segment's moving anterior and the rule is same. So extension is anterior roll and anterior slide. Flexion is going to be the opposite. Now we have a posterior roll and a posterior slide because the moving segment is moving in the posterior direction. So let's review both of those quickly. Open chain knee extension, anterior roll, anterior slide. Open chain knee flexion, posterior roll, and posterior slide. So that's a quick overview of the arthrokinematics of the knee joint. In next week's episode, we'll talk about some of the structures that are involved in those arthrokinematics, because they're not just magic. The structures of the knee joint help that out. Thank you for joining me for this first episode of our knee unit. Today we review the bony anatomy, alignment, and arthrokinematics of the knee. In the next episode, we're going to continue our knee unit with a discussion of muscles and movement. Thanks again for watching, and don't forget to like, subscribe, and leave me any questions you have in the comments. I'll see you next time.